that at the end of this conference on Sunday, that I'm going to approach AATA to actually define my status. Having spent 4 months in IAS, they still consider me as a guest. I would like to thank you for inviting me and for my colleagues that have actually laid the foundation for the presentation that I'm going to make now. This is my presentation outline, and I would want to reflect on one of the key texts that actually presents very clearly God's health agenda to us. And in the presentation, I'm going to reflect on some measures the global community have taken to respond to the global health issues facing Africa. And I would want to come up with some recommendations that I think the church needs to pursue at this period of our history. This is God's agenda for you and I, and for the church. And it is a divine agenda that we prosper in health. And I call it, or I say that God wants health for all Adventists and all for health. Health is also a global agenda, and it is aimed at complementing God's wholeness agenda. Even WHO recognizes this. So there was a state of incompleteness, and hence the need for us to move towards the agenda that will help to create completeness. I would like us to reflect a bit on these scary statistics already presented by my colleague. And it's such a contradiction, because while God desires health and WHO promotes health, and religious bodies, including the Adventists, of course, are involved in health, yet this is the kind of statistics you find in Africa. It's in fact scary, because this is contrary to the wish of our Creator. In fact, it's not in his agenda that anyone should die of malaria, yet malaria, which is a preventable disease, kills many Africans. The trend is actually disturbing, because today we are talking about HIV, we are talking about malaria, and in recent times we moved over to Ebola, and who knows what will come next. I would like to highlight some of the global responses to disease conditions, not only in Africa, but of course globally. As far back as 1978, the World Health Organization and UNICEF conducted or carried out a big international conference in a place called AATA in Kazakh Republic, where primary health care was adopted as a global strategy to achieving health for all by the year 2000. And 40 years after AATA, Africa's poor health condition remains poor. And of course, from AATA to the Millennium Development Goals, we spanned from 2000 to 2015. It's gone, yet Africa's health is still in a precarious state. Even though impressive progress in reducing child mortality continent-wide was achieved somehow. Of course, there was this under 5 mortality rate reduction from 146 per 1,000 to about 65 deaths in 2012. Despite this, other indicators actually appear disheartening. And from AATA, with about 8 critical components or elements, which was, of course, later extended to 10 rather than 8. It was aimed at achieving the goal of health for all. But in the Millennium Development Goal, of course, another 8 goals were scheduled. And now we have 17. And one would want to still ask, with all of this, is there hope for Africa come 2030 when the Sustainable Development Goals expire? I would like to remind us of where we are coming from. Because if Africa's belief system shapes health behavior, then I think we need to begin to consider or think of new strategies to address the health needs of Africans. I would like to remind us of where we are coming from, and for us to note that our health system appears to be overwhelmed by so many factors. We have this historical past that comes with so many baggages. A system that is hospital-based, clinically biased, doctor-centered, patient-oriented, a system that is generally and basically curative in nature and largely inaccessible. And of course, with this obvious imbalance between curative care and prevention. Indeed, Africa's health problem or health system is overwhelmed by the realities of our time. And sometimes one is tempted to ask, where is the ministry in the ministries of health in Africa? Then from Africa's health system to Adventist health ministry, how far have we gone? Of course, we've done so much, we've come a long way. We have functional health facilities in different parts of Africa. Some of them were highlighted last night. A mission-oriented health programs and facilities. And it's interesting to note that our ministry as a church actually predates the major global development goals. If you will recall, our health message as propagated by Mrs. White was revealed in 1863. And that was about 115 years before AATA declaration in 1978. And this suggests very clearly that as a church, we have a legacy that is about 115 years older than what the international community is presenting. And I wish to also remind us that with this legacy, we are challenged to reflect on this statement by Mrs. White, made as far back as 1942, that too little attention is given to the preservation of health, and that it is far better to prevent diseases than to know how to treat them when contracted. And so on this basis, I would like to submit that as a church, we have this advantage, which I call the Adventist advantage, because we have evidence beyond science, evidence that is Bible-based, evidence that is historical, evidence that is hinged on the power of prevention. We are blessed with the spirit of prophecy. We are blessed with results from the Adventist health study, even though those studies were conducted in North America, but we have a lot to benefit from that, even if we are from Africa and Asia and all of that. And we, as a church, believe very strongly that the health ministry is the right arm of the gospel. And this we have also amplified by creating what I call a superb organizational structure by way of having the Adventist health ministries at all levels of our church, beginning from the local church to the division and even general conference. So we need to be reminded of this legacy that actually shows very clearly that we need to do more in promoting health in the church. From the figure there, we could see that the biblical historical evidence, which is what I would call the Adventist advantage, is superimposed on top of the evidence triangle, which of course suggests that we have something more superior than what the world has. But the challenge is if a study is conducted to ascertain the health status of Adventists in Africa versus the general population, what will be the result? Of course, the result in North America is clear. But would we expect better health outcomes for African Seventh-day Adventists? I have some recommendations to make, and I think that the time has come for us to act locally in addressing the health issues in Africa. And I am strongly recommending the need for us as a church to employ public health professionals as district health educators, just the same way you have district pastors, you have district health educators, well trained to address health needs in a more sustainable way, to develop what I would call Made in Africa health programs that are delivered using culturally oriented strategies. With this recommendation, I see a situation where we'll begin to avoid what I call the current hit and run approach to health education in our churches in Africa. So for a sustainable, community-based, church-oriented, church-centered health empowerment programming for our people in Africa and even beyond, there is need to employ public health professionals to serve as district health educators. And with a project like this, of course, the coordination must be from the conferences through the districts and supported by the conferences. I have also attempted to present the modus operandi for this, and that would include having these district health educators live in the districts and capable of understanding and speaking the local language. They are knowledgeable about the culture and attitudes of the people, and with trained professionals leading out, they will have this ability to assess and plan and implement and evaluate programs. Because of the need to ensure that the district health educator project is sustainable, there would be need for a district health committee that will guide the operation of the district health educators. And I have outlined the composition of the committee. And this committee, working closely with the district health educator, will be able to identify the health needs of the district and identify the resources that are needed to address those identified needs. And of course, they are not expected to work in isolation. They need to also work with other stakeholders, Adventist Health Ministries, ADRA, Adventist States Ministries, and even secular public health departments. I recognize that our resources as a church is limited. And of course, the investment may seem to be enormous, but I think the benefits are invaluable. There may be several models to this. The best case scenario that I think that I'm presenting is a scenario where you have a district health educator per district. But other models may include having or creating health zones within a conference and then hiring some of these district health educators to direct the health programs of those zones. The resources are already there. Adventist universities are producing many graduates of public health, and it's, of course, it's not as if I'm campaigning for a job for my students, but I'm thinking more about the outcome of a project like this. And of course, the departments are always willing to help support with generating the materials, the information, education, and communication materials that may be needed by the district health educators to perform their roles. And the coverage should include all the churches within the district or within the conference, suggesting a need for a map that defines the target areas. And of course, this would help in developing regular programs that are sustainable. And I'm making this recommendation based on the fact that for now, the hospital-based only care and promotion that we as a church focus on is not quite sustainable. It's not enough. So there's need for a balance between curative services as a church and then prevention. The syllabus to be used by the district health educators will be based on needs as defined, as defined from the initial assessments that will be conducted in those districts. So the health education agenda for District A may not be the same as the health education agenda for District B, because the needs may be different. And of course, the modus of the mode of delivery of health education programs should be tailored or should be tied to the local needs of our people. We come from a continent where oral tradition is important. And so using culturally appropriate methods of conveying messages may seem to have, may likely have a wider impact. And I mean culturally appropriate methods like storytelling, skits and songs and parables and those things that are very, very culturally tied to, culturally relevant to Africans. And of course, there should be some kind of supervision by the conference and of course even the division and other levels. But the operational base should be the district. And as a pilot, or as a starting point, there's need for a baseline survey, that will, of course, reveal the needs, and not only the needs, but also the resources available within those districts to address those needs. So in conclusion, I would like to highlight the fact that as a church we have a legacy to teach, practice, and sustain healthful living in Africa. And by doing so, we complement the efforts of government and other stakeholders. We need a model that integrates prevention and care, especially at this period of our history. There is need for us as a church to recruit and pay district health educators to develop and implement action-oriented, community-based, church-centered health education programs. Of course, public health professionals hired to take up these positions, not only as district health educators, but also directors of health ministries, are more likely to effectively deliver and coordinate sustainable preventive health programs. Thank you.
Okay, thank you, Dr. Aja, for that fine presentation. Now, because I can see we are running behind schedule, I'll only take 2 short questions. So, any question? Okay, Prof. We had a mobile microphone somewhere behind there. Thank you, Pastor Mbiriri.
Thank you, Dr. Aja, for the wonderful presentation. I agree fully with the concept of the district health educators. And I think it is true that it's time we did away with placing pastors as health directors in the conferences and so forth. It's a little challenging, though, at the districts, because the pastor is the one who is really pivotal in making sure that this program takes off. I was just suggesting, not so much of a question, that is it possible that at the seminaries and schools of theology where pastors are trained, the curriculum could actually intentionally include some aspects of public health? And if so, what challenges do you think might be experienced in trying to follow that route?
Thank you very much. It's another model that could be explored. But beyond that, my position is more on really having professionals really coordinate the health ministry's agenda of the church. I'm talking more about sustainability. Of course, providing our ministers with some background knowledge about health is important, because like I projected, the district pastor is much more likely to become the chairman of the health committee. So having some basic knowledge of health is important. But when it comes to the actual implementation of health programs in the districts and the churches, we need expertise. And it's interesting to note that in our churches we have these resources, and we need to really invest on the resources that we have so that we get better results. Because if a district health educator is hired by the church and paid by the church, of course, that comes with a well-defined terms of reference. and with measurable indicators to say that, you need to report to us the extent to which your programs is impacting on the lives of church members. And I want to even hypothesize that if a sustainable health agenda is put in place in our churches, and people are motivated to live socially and economically productive lives, they probably might, tithes might increase because people are more healthy to work and generate resources that will come back to the church and help with the running of the system. So beyond training, beyond adding few courses to the classes that our pastors take, yes, that's fine, but I think having qualified health professionals as leaders of our health ministry, even at the district level, is what I'm submitting. And I'm hoping that in the near future that we'll pilot this project in some settings and see how it works. But I think it's something that we need to pursue.
Thank you so much, Dr. Aja. Because of time, I'm not sure if you can take another question, but Dr. Aja is here in IAS. You can always meet him and talk to him. I believe there'll be time for that. Otherwise, let's give a hand to Dr. Aja. Thank you very much. God bless you.
Thank you.